Welcome to everybody. It's my great pleasure to say good morning from Scotland. My name is Anne McMahon and I am co-editor-in-chief of the Journal of Research in Nursing, along with my fabulous colleague, Angela May. This is the second mid-pandemic online event that we've held at the Journal, and we're delighted that this one in particular we're hosting in partnership with an organisation called, I have to check this to get this right, the World Organisation of Family Doctors, also known as Wonca. Now, it's my pleasure this morning to introduce you to my friend and colleague, Joyce Kenkre. Joyce is an emeritus professor of the University of South Wales. Joyce is a nurse and she's a member of the Journal of Research in Nursing editorial board, and she's a council member of rural Wonca. So without any further ado, I'm going to hand over to Joyce, who's going to chair today's event. Thank you, Joyce.
Thank you, Anne. I'm delighted to welcome you all today from around the globe. The context of this meeting is that I co-edited an edition of the Journal of Research in Nursing on Rural Health, which was published last year. In the edition, we published a perspective entitled, "Now is the Time to Raise Our Voices." We did this in part to raise awareness of the landmark position statement developed at the 16th Wonca World Rural Health Conference in Albuquerque in October 2019. Known as the Albuquerque Statement, it calls for leadership roles for nurses and midwives worldwide in the collaborative process of achieving universal healthcare coverage. The statement was fully supported by family physicians at the conference and the executive committee of Wonca. As nurses, we know that change will only happen if we work collaboratively across healthcare professions and within communities. The aim of our conversation today is to explore how we may advance the leadership potential of nurses and midwives globally to realise universal healthcare coverage across rural communities, and will shortly be my pleasure to introduce you to our panel of discussants. But before that, I want to focus on your engagement in this conversation. Please let me introduce you to JRN editorial board member Mark White, Vice President of Research, Innovation and Graduate Studies at the Waterford Institute of Technology in Ireland. Mark will explain how we will use Zoom to support our conversation and your participation in it. Thank you, Mark.
And thank you, Joyce, as well. I see we have a test question already posted for the panel, and that is great because Lou has done that for us, and we're going to be using the chat facility as well on Zoom, but we're going to manage the questions today on the question and answer facility. So you'll be able to see our panel members on your screen. That's the first thing. The second thing is you won't be able to hear or anybody else. People have been silenced, and in order for you to engage in the conversation or to invite, we invite you to post questions in the question and answer session for the panels, and we will collate them throughout the morning. And just please indicate if your question is a general question, or if you if it's for detail in somebody specifically. So please do that. Just mention it if you do. If you want to share an experience that you've had that resonates with you, or members of the panel in terms of what they're saying or talking about, please use the chat facility, and we will be using the and monitoring the chat facilities to collate them at the end, and we will present them at the end of today, and I'll do that through Joyce at the very end. We're hoping that the technology will run smoothly today, and we've allowed ourselves a little bit more time just in case, but I can see there's plenty of participants online as we're talking. If there's any glitches, we just ask you to stay with us and hold on while we work through some of those and we get our transmission going again completely if there is a disconnection issue at all. We are recording the conversation, so you'll see that came up when you logged in, and we'll also be posting today's event on our JRN YouTube channel. So you can see it all again, or you can pass it on to colleagues who weren't able to attend here today. I'm going to hand you back to Joyce. If you have any problems at all with the question and answers facilities, you can drop me a message in chat either, and I'll be able to get on those. So you can like questions as well, and you'll see if you want to test that, you can click lose question there now and see if you like it. And I'm going to hand you now back over to Joyce.
Thank you, Mark. Our panelists are Bruce Chater, he's going to appear soon, who is chair of the Wonca Working Party on Rural Practice and a working GP for the last 38 years. Bruce will discuss workforce issues around ensuring multidisciplinary working. Going to introduce you to John Wynn-Jones, is the immediate past chair of Rural Wonca and founder of the UK Institute of Rural Health and the European Rural Isolated Practitioners Association. He'll reflect on his experiences and the future role of the team in achieving universal healthcare coverage. Barbara Stilwell is Executive Director of Nursing Now Global Campaign. Barbara has extensive experience in rural health in low and middle income countries. Barbara will be discussing how we can take forward the issues arising from Nursing Now campaign within rural communities. And Shelley Nowlan is Chief Nursing and Midwifery Officer for Queensland and newly appointed Deputy National Rural Health Commissioner in Australia. Shelley will share with you some of her views on leadership to address the global need for universal healthcare coverage. So without any further ado, I'd like to hand over to Shelley now. Shelley.
Good evening or good morning to wherever you may be across this globe. Leadership is important at all levels for all of us as clinicians, whether we may be nurses, midwives, doctors, allied health professionals. The important documents that have been released recently is our Albuquerque statement that Joyce earlier inferred to, but most of all, the State of the World's Midwifery Report and the State of the World's Nursing Report. From a leadership perspective, if you want a 101 on what we need to do as nurses and all midwives across this globe, we really need to focus on the global workforce shortage that we are experiencing. COVID has put us under siege and we are now responding over and beyond our capacities. But moreover, rural and remote communities, regardless of even being touched by COVID, are experiencing these shortages. We also need to focus on the bold investment of governments and leaders who have resources that are available to them. In 2021, the analysis indicates a shortage of 900,000 midwives. For nurses, this is also a significant experience in regards to 8% of the workforce being under siege and under resourced. The bold investment needs to focus on both professions in regards to education and training so that those peoples working in your community have the option and the opportunity to actually become healthcare professionals. Health workforce planning, management and regulation, and the workforce environment that attracts and retains both nurses and midwives. Leadership and governance is paramount for this to happen. And what we're all here for is service delivery, making sure that those people that are in the most remotest rural communities have access to first dose treatments and ongoing care. Nurses and midwives join their colleagues, their medical professions, and actually provide this in significant numbers across the globe. Particularly with technology now, we can be lifted to ensure that high quality education and training, high quality care and advice to these professions can be available. So my call out, my shout out is to build leadership, stewardship and management capacity of the nursing and midwifery workforce. Join with your colleagues, look at the investments in nursing through adoption of required policy outcomes. There are many policy levers that can assist to accelerate and sustain additional investment in nursing and midwifery across this globe. Thank you for joining us, and I look forward to further discussion. Over to you, Bruce.
Thanks, Shelley. I'm Bruce Chater. I'm the chair of Rural Wonca. It's a funny title, but it's the World Organisation of Family Doctors. And we're the rural group within there that's 25 years old. I'm a doctor in a small rural town in Queensland, Australia. We've got 3 doctors, 2 trainees, 2 medical students, and over 20 nurses. It just shows you the importance of nurses to us in our general practice, our ED and our hospitals. So I've just driven down from there to our Rural Doctors Conference in the southeast of the state, 7.5 hours drive today. It's really quite a vast country, but there's, no matter where you are in the world, there's a lot of characteristics of rural that mean that we have much more in common than we do that separates us. And I think that applies to the professions as well. On Rural Wonca, we're not a representative organisation. By that I mean we don't have doctors or others from our constituent bodies in that world organisation. What we are and have been is passionate rural doctors or rural doctor academics. But recently we decided that we really needed to broaden that, and we needed to invite nurses to join us on that board. Now that's pretty unusual. We're probably the only one that has done that to this extent in what is a doctors' organisation, but we recognise the need to spread that. And the first sign of that increased focus was the Albuquerque statement that Shelley just mentioned. And I'll just talk a bit about some of the key things that we pledged in that, and we managed to get the whole of Wonca to agree to this, but it was about supporting the rural and remote nurse and midwifery voice by inviting nurses and midwives to participate in decision-making and leadership, advocating the need for equity and participation, emphasising the need for generalism in nurse training and practice, particularly for rural practice, promoting collaboration in reviewing our mandate and making sure that nurses and midwives are included, embedding research and data collection, promoting full scope of practice in rural generalist nursing, and support for integrated family and patient-centred team-based care that addresses community needs. That's what rural health's all about, is that team-based and the ability for us to work together and have that mutual respect. We've been working for 25 years in Rural Wonca on getting the evidence for recruitment to rural areas. And that was recently published in a blueprint for rural health from our last Rural Health Conference, which was held online. We want everyone in rural, whether it's nurses or others, to be working at full scope and at times at extended scope. That's the only way we're going to get good services into rural areas, is for everyone to really step up, work as a team, and not knock anyone down, build everyone up around us. And we're big on that, big on what we call grow your own, making sure that nurses, all the nurses in my practice, come from our town and they've all gone away, done their training and come back. We want that immersive training. The context is important. Nurses need to learn, be competent, confident, comfortable and content in rural areas. So I think it's wonderful to join you. I'm very happy to talk about the need to have rural generalist nurses to accompany rural doctors and others in rural areas to provide an excellent range of services. So I'll hand over to my predecessor in the chair of Rural Wonca, Dr. John Wynn-Jones.
Thank you, Bruce. As well as looking to the future, I think my role today is to reflect as a retired clinician with a past experience working within a fully functioning primary care team. I'd like to take the opportunity to reflect on what worked and what didn't work in my 35-year career. Today our focus is on nursing and nursing now, and I want to emphasize the huge contribution of nurses to the rural primary care team. I've no doubt that rural healthcare would not exist without rural nursing. And it's been shown in places that sometimes when doctors are not available, there's always nurses who run the show. So I want to take you back to a small rural practice on the Welsh-English border. And I started as a full-time doctor in a small town of Montgomery in 1997. And things were different in those days. But the area stayed much the same. The town population was 1,200. Our practice covered 300 square miles. And we took in a dispersed population of about 7,000. The main employment was farming, forestry, light industry, and many people traveling distances to larger towns. I came from a training in London, surprisingly, but I was fired up by two extraordinary trainers who instilled on me the benefits and importance of working in a fully functioning primary care team. And that back in the 90s was kind of early, exciting stuff. Back in the 70s, sorry, it was really exciting stuff. And in the early years, we moved into new premises in our practice, and the team grew over the years. And some of those in the team included community nurses. There were nurses that worked out in patients' homes in the community psychiatric nurses. I don't know how I would have coped without community psychiatric nurses, palliative care nurses, which can revolutionize the care of the dying in rural practice, midwives, and initially our midwives were duly qualified. They were community nurses and midwives. And that's a really interesting mix. Health visitors. Now, for those who don't know, there's a public health nurses, practice nurses, nurse practitioners. We had healthcare assistants. We had a physiotherapist attached. And we had the occasional visits from an occupational therapist. And we also had a social worker attached to us. We had access to 2 community hospitals for inpatient care and for maternity services. And we also established a patients association, which helped us direct practice and provide feedback. The team met once a week to discuss problems and the way forward. Now, it was my belief that for a significant period of time, we worked well and we met the criteria and aims outlined in the United Nations Astana Declaration of 2018 of developing a fully functioning multidisciplinary team. And to quote the Astana Declaration, they talk about health professional working at the primary care level to respond effectively to people's health needs in a multidisciplinary context. Sadly, things began to go wrong. Up to that point, we managed our own budget, but political pressures deemed that there should be more central control of working practices and budgets. The community nurses around the area were gradually taken away from practices. Health visitors worked elsewhere. They moved to a caseload as opposed to a locality practice-based working practices. In the late 90s, I was involved in an initiative that we call local care teams, which took the concept of multidisciplinary teams one step further, bringing in other rural services and trying to provide multidisciplinary package for our patients. Sadly, politics changed and the plan was never implemented, but I think it was really an interesting plan, and I think it's something that people should look at again. And it's interesting, in Wales and England, there are ideas now beginning to emerge around this. So finally, my reflections for today, I suppose my hit list that I would like to say is important. Nursing is essential and vital to rural practice and to universal health coverage. Without rural nursing, the vulnerable could not be looked after in their own rural communities. We need to raise the status and recognition of rural nursing and its contribution to rural health through media, academia, policy engagement, and whenever possible. We need to emphasize, as Shelley said, the importance of leadership. And we need to set up developments to build up leadership programs in nursing. Rural nursing needs to be an academic subject in its own right. We need to establish academic streams dedicated to team development and research. We need to develop those teams further, but they will be dependent on local resources, the context, health systems, configurations, whatever. But remember that the sum of the total will have a much greater impact than everybody working in isolation. Teams should be attached to defined populations and work as a unit. They must have some degree of autonomy and possibly some control over budgets as well. Now, probably one of the most important things, I think we need to move over from the idea of working with qualifications to working with competencies. When we decide tasks, it's really who's competent to do that rather than who has the qualifications. And finally, teams must not work in a hierarchical way. We all bring different skills and there's enough work for everyone to go around. So thank you. And I'd like to now hand over to Barbara Stillwell. Thank you.
Thank you so much, John. I absolutely love your vision. Sign me up immediately. I love the idea of team education streams and non-hierarchical teams. That's fantastic. So good morning, everybody. My name is Barbara Stillwell. I'm the immediate ex-director of the Nursing Now Global campaign, which finished a couple of weeks ago. And was hugely successful for reasons that I will talk about. I think it came at really the right moment. But first, thank you to the Journal for Research in Nursing and to Wonca for inviting me this morning. I'm very honoured to be with you, all such visionaries in this field. So I want to talk a bit about the Nursing Now campaign and what we learned from it. And a lot of what I'm going to say resonates with what my colleagues have said already. The Nursing Now campaign began because an all-party parliamentary group in the UK decided to take a look at the contribution of nursing to global health. And what they found was, based on the evidence, that nursing has a triple impact. It results in better health, stronger economies, and greater gender equality. However, despite the evidence being pretty clear on this, nurses said around the world that they felt often invisible, undervalued, that they didn't have high status as health professionals, and their profile was really not a strong one compared with other health professionals. So Nursing Now was established to raise the status and profile of nurses, but not to do that for its own sake, but to look at how doing that improved health and health care. And I think rural health is actually a great example of the way in which nursing can make a considerable contribution. We know, those of us who are nurses, and certainly I'm sure my co-nursing panelists would endorse this, that nursing is a highly researched profession. We know an awful lot about the effects of nursing, about the contribution nursing can make, and yet this research does not get turned into policy or indeed into advocacy for changes in policy. So what we do see are wonderful developments such as Bruce was talking about. I mean, how fabulous to have 20 nurses and, you know, a smaller number of doctors and some medical students and dare say other health professionals in a practice. That really turns the workforce requirements on its head. And this, I think, is one of the recommendations that will come out of Nursing Now, is that we start to look at workforce in a different way. During Nursing Now, we did a survey of nurses globally. We had over 3,500 respondents to that survey, which I think shows the level of interest in nursing and nurse leadership, which is what this survey was about. And we did it because almost every single report that has come out of WHO, indeed out of almost anything to do with nursing research, recommends that nursing leadership should be strengthened. What do they mean by that? Well, these reports tend to mean there should be more chief nursing officers, more senior nurse leaders, but mostly, I think, digging into them, what they mean is nurses should be more visible, so they should be able to speak out. When we did our survey, we found that more than half, actually 60% of nurses globally felt they couldn't speak out. They either felt they didn't have the confidence, they couldn't use data to speak out, or they felt intimidated by the people that they were with in the settings they were in. Some of them felt intimidated because many of their colleagues were doctors and many of them were men, and they felt they were breaking into a world that they couldn't or shouldn't break into. And of course, that's very contextual, isn't it? But if you look around the world, there are many contexts still, sadly, where elevation to senior positions in healthcare are held, those positions are held by doctors, and still, I know it's not the case in the UK, but still in many countries, most physicians are men. So that dynamic persists. And I think there's a lot of that underpins the great success of nursing now. We actually were established in 126 countries. We had over 700 nursing groups around the world who I think took advantage of this platform to convene not only other nurses, but also people who weren't nurses, their physician allies, their allies who are not even health professionals sometimes, and to include ministers of health and other policy folks, so that their messages could be heard outside nursing. So I think what we provided was a way for nurses to become better at advocating for themselves as part, as John has said, as a significant part of a healthcare team. And it's really sad that nurses in many rural areas, particularly in low-income settings, they fill in all the care gaps that there are, but they are not, those roles they develop to fill in the gaps do not become part of policy or legislation. They're not formal, and sometimes they're not even seen other than by patients, by clients that those nurses work with. So what we did was provide a convening platform for nurses to bring people together and say, look, this is what we do, this is what we can do, this is what we need, invest in nursing. And my hope is that now we've seen what that can do, and it was tremendously successful because of the energy of the groups and the countries involved, that we don't lose that dynamic, that new narrative about nursing that we have seen over the last 3 years. I believe, as my colleagues have said, there does need to be a radical rethink of workforce planning. It surely must be based on competence. We know from research, from really good, respectable, radical randomized control trials, that nurses who are advanced practitioners, trained in primary healthcare, can provide 80% of the care. And that's so important for us to know on so many levels. As my colleague Joyce Kenkre and I used to reflect in many, many years ago, decades ago, when we were testing new nursing roles, we don't need to be competing for work in primary healthcare. There's plenty of work for all of us to share and to give our best, the best we can give to each of those cases. So each of our patients and clients gets the very best care they can get, depending not on what we think our role is, but what we can offer and what that person needs. And that's the essence of true patient-centered care. So we need a radical rethink of workforces. I believe we need to get nurses into an educational stream where they can get much better at converting what the research is into what policy requirements are and what legislative requirements are, so that new roles become embedded. We need to have our allies like John, like Bruce, people who are outside nursing, but understand what nursing brings and can really work with us to make sure we get the best impact for what we do. And I think nurses also need to get better at understanding the health system, systems thinking for health. So we understand better what the budget is, we understand what our roles can bring, what our competencies can bring. We make those links with education. So we have work to do ourselves in nursing, no doubt about it. I believe we can really, by empowering nursing, we can really bring together the health workforce, and we can improve and deliver care that's much more comprehensive, that's flexible, and working as teams, we can actually have a really good time. That's certainly been my experience. So thanks to my colleagues, thanks for the invite, and I look forward to the discussions. Back to you, Joyce.
Thank you all for your presentations. Mark, can you come and join us now?
Yep, thank you, Joyce. We've had a number of questions here. And I'm going to take the first one from the top, and they're just by way of, by the way that they've been ticked or liked. So the first question, you might choose the participant to answer this one. It's almost a political one. How do we ensure leaders understand the special needs and contributions of nurses and midwives working in remote communities?
Thank you, Mark. Yes, unless a question is directed to a specific panel member, I'll identify who is best placed to respond to each question. Panelists are encouraged to raise their electronic hand if they particularly want to include their response in, but keep to the point so we can get through as many questions as possible within the time available. So would you like to repeat the question there?
Yep, sure, Joyce. So the very top one there is, and as I said, it's a political one, I think. How do we ensure leaders understand the special needs and contributions of nurses and midwives working in remote communities?
Do you want to start, Bruce?
Yeah, look, I'm happy.
Unmute there, Bruce.
Unmute.
Sorry, they say that's the meme for this this year, isn't it? You're on mute, Bruce. Look, I think there's rural doctors ourselves have to push up against our profession a fair bit, and I think so. We share a fair bit in common with nurses pushing at the boundaries. I think we need, in particular, I think rural doctors and rural nurses need to get together. And I hear the question saying about how do we improve the lot of nurses. I think it's about improving the lot of patients together and showing how important we are to that process, and then being appropriately recognised for what we do. So I think it's about showing bang for buck, if you like, that we can really produce good results, and that's why we need everyone working at the top of their skill and being recognised for that. Patients want to know that they've got good doctors, good nurses, well-trained doctors, well-trained nurses. We need rural generalist nursing. We need rural generalist doctors who can show those skills, and the communities will give it back in buckets full, and they will support the recognition of those people up to politicians and up to the policymakers. We need to hear their voice as well as our voice. Thanks.
Shelley, would you like to just say some of the issues that maybe you've come across?
Without a doubt, without a doubt. It's the same as what Bruce is saying. It's our consumers, it's the communities that really shout out and raise our voice of the value that we do. In relation to care, but we need to optimise the top of licence, the top of scope, and this is done through policy levers such as regulation in countries around the competency assessment. Everybody wants to make sure that whoever delivers care to them is competent and is able to do that. We also need to make sure that it is understood that the nurses and midwives that are in those communities who are educated, they're educated to a standard of that country. And if we don't lift them and if we don't use that, that's the economic waste. We also understand that in the most rural and remote communities where we can have local people providing care, we actually lift the wealth of that community that can then further invest in their children's educations, and we have this roll-on effect. So it's a shout out, the Morgan Gallup poll this year and every other year since it was held have the most ethical, responsible workforce as nurses, followed by doctors, and this year it was pharmacists. So, you know, healthcare is set to have that trust by all of their communities, wherever it is, to actually provide the best and to support the best to deliver that care.
Barbara would also like to respond.
Yes, thanks, Joyce. I'm just reminded of when I, in my previous role before Nursing Now, and I was working in low-income settings, and I met a young man who was a nurse who had been posted to a rural area. It was actually in on the African subcontinent. And in the country he lived in, they didn't have any choice. They had to go and do a couple of years in a rural area, and they were posted there. And he was telling me that he arrived in this place. He had, you know, hardly any warning that he was going. He arrived in this place, and there was nobody to meet him. And he got off the bus, and the villager said to him, "You'll be living in this house." And he said, "I walked into the house. There was another family already living in there, so I would have had to have shared with this family." He said, and the toilet was just unusable. It was just absolutely horrific. And he said, "I just got on the bus and went and left." And I was thinking to myself, you know, when he told me that story, it's not rocket science, some of this, is it? You know, we have to provide for the people we ask to go and work in rural, remote areas. They need the things that people who are not in remote areas need. They need schools, houses, internet, the ability to connect with their family. And, you know, we're asking them to go in some rural places to go and work in places where there's mosquitoes the size of helicopters. You know, we need to be aware that we're not asking them to a party here. So we've got to, you know, when we say invest in nursing, that's what we mean. And it's not only nurses, we need to invest in the whole healthcare team if we're asking them to go and do these difficult jobs.
Thank you. John wants to respond as well.
Yeah, it's really just a quick one here, Joyce. I think, you know, I think some of this starts very early on. And one of the things that I feel kind of quite, it's really important, and I've realized how important it's become over the years, is the importance of understanding public health issues. And actually, we don't get enough training. We don't get enough introduction to public health as all primary care workers. It's not only doctors, it's nurses as well. If we understood public, if we were able to put that into practice and actually be able to use the data, as Barbara says, there's a lot of data out there. It's just that actually we're not good as individuals at using that. So I remember we developed a chart of a rural practice in Europe, and I sent it to Roger Strasser for comment, and Roger came back and he said, "You've left the word public health out." So we need to understand how public health works.
Thank you. We have quite a few questions in the question and answer box. So next one, Mark.
Yeah, and the next one it kind of alludes to what we've been talking about, incentivizing. So there's a question here to the panel, and it's not addressed to anyone in particular, Joyce, but do you think it would be worth incentivizing nurses and healthcare teams to work in rural populations and the opposite or antithesis of London waiting. So give people more money to work in rural health teams.
Shelley would like to respond first of all, then John, then Bruce.
Yeah. So many of our organisations in first world countries already do incentivise from a financial perspective and assisting with things that Barbara highlighted in regards to suitable accommodation and transport there. But what lots of the research has actually shown is what does attract people to rural remote areas is the breadth and depth of application of their knowledge and skill to provide the services to that community, engaging as a team with doctors and allied health to provide place-based care for the community that they live in and that they breathe in. And you know, it is not just all about the medals that we wear and how well we do these things. It's a combination of acknowledgement, remuneration, recognition, further investment. Many people move to rural remote areas to actually have the autonomy of practice, but also to develop leadership skills and be able to advance themselves in regards to a voice to ensure that there's quality services provided across that. So yes, incentives are needed, incentives are warranted, but at the same time, it's also that natural component of self-worth, being valued and recognised by your peers.
Thank you, John.
Yeah, thanks to Joyce. Both Bruce and I have been involved working with WHO on a programme about the retention of health workers in low-income countries in rural remote areas. And I think Bruce is probably better qualified to speak about that. But what I want to do, Bruce and I attended a workshop in Dublin at WHO workforce conference, and we really went to an amazing lecture given by the World Bank, where they looked at actually incentivizing healthcare workers in rural areas. And yes, money is important, but actually there are other things, as Barbara suggested, that are equally and probably more important. In many countries, it's about safety. It's about the quality of housing that you have. It's about the team that you work with and the premises and the equipment that's there. It's about, what about work for your partner, your husband, your wife? What about your education for your children? It's actually a lot more than just money. I'm going to hand over to Bruce now because I know he's going to elaborate on that.
Yeah, look, I think the World Bank's done some great stuff, and I might see if I can just find the reference and put it in chat, but I can certainly give you some information on it if people are interested. It's a dose response curve for those of you who look at drug reactions. There's a dose response. It's a bit like the hemoglobin saturation curve and all those ones. There is a trend up, and it lags a bit and then goes up. But blow me down if you actually, to take all the points that people have made, if you make it a satisfying workplace, it shifts the dose response curve to the left. If you then give people reasonable housing, to quote what Barbara was saying, it moves the dose response curve to the left. If you then support their spouse, it removes the dose response curve to the left. And it's a beautiful little study done on Ethiopian midwives, actually. But the piece of resistance to that was if you gave them gloves, it moved it a long way to the left. So there's a whole lot of things. You need to understand what's important for people in rural areas. And to quote Barbara again, people should be able to expect in rural areas what they expect in the city. There's a term called geographic narcissism, which is, once again, a really interesting paper, but it's by a psychologist who describes the city as seeing itself as the center for everything, and that we should have to deal with less standards. That shouldn't apply. It should be that there's equal opportunities. And if those opportunities are provided, the dose response curve shifted to the left, and there's not as much need for incentives. I'm not saying there isn't, but there's more to it than just money. It's that whole package. Thanks.
Thank you. Barbara, you want to speak?
Yes, thanks, Joyce. I just actually really wanted to echo something Shelley said, that you know, a lot of incentivizing people to do a good job is about the way they're valued in the workplace on a day-by-day basis. So they feel that they're making a contribution to something even greater, you know, than the day-to-day. They're sort of, they feel that they're contributing to the health of the population, for example. And so a lot of that depends on good management. And we haven't really mentioned management, but I think, you know, for many nurses that work perhaps not in teams, but in isolated rural areas, maybe by themselves sometimes, it's really important in health systems to think about how they are supervised in a way that supports them rather than chastises them or penalises them. And we don't often talk about management, and often it's demonized, but it is critically important. And so I urge us to think about how we set up those systems too.
Thank you. Mark, our next question.
Yeah, and the next question has actually just been answered, so I've put that in the answered section, but the next question is of interest to me as well, because it's in relation to examples of interdisciplinary education in rural health, and I'm really interested in this one because it's the panacea and nirvana of all education to have it interdisciplinary, but we seem to fail miserably. So I'm interested in the answers the panel might have.
Bruce would like to start.
Yeah, I want to change the focus. What we talk about is interdisciplinary education. What we should be talking about is interdisciplinary learning. Everyone being preached to work together doesn't work. What you need to do is learn together. So we talk in rural about immersive education, and the doctors in our practice learn to get on and work with nurses because they know their day-to-day work depends on it, and that they're actually in a system that works that way. So they actually learn work together immersively in a rural practice. I think trying to preach to people before they go to practice or outside practice to go and work together doesn't necessarily work as well as just having them together and saying, you know, you're going to learn together. And we've got student nurses, student doctors who see the role modeling going on and actually work together. So I think it's about immersing them in that environment, and the rest will follow.
Thank you, Bruce. Shelley, would you like to respond?
Yeah, just moving on that and alongside of Bruce, Maslow's hierarchy of needs. The first part is to feel safe and to feel protected, and collegial generosity actually provides that, you know, through that learning environment where, you know, the only fault is if you don't recognise mistakes. Mistakes is the power of learning. And all of us who are licensed professions, we sign up our registrations each year to say that we're qualified. And part of that is saying that we're going to share, we're going to immerse, and we're actually going to support others to learn. So by embracing each other, being isolated and remote and having a lot of those biopsychosocial protections removed from us means that we actually need to provide that for each other, and professional generosity in learning, education, training is significantly important.
Thank you. Barbara, you'd like to respond?
Yeah, just not about courses particularly, but one of the findings of our study was that nurses really highlighted the importance of mentorship and coaching in practice, which speaks to this idea about learning rather than didactic education, that we all learn every day. And I just wanted to float this idea that maybe we need interdisciplinary mentors. So maybe some of the physicians should have a nurse mentor for a while, you know, and the other way around. I mean, maybe we just need to start mixing and matching and see how that changes how we think of the other profession. When my daughter was a student nurse, they had a scheme, one of the London hospitals, where the medical students came and worked as nurses for a couple of weeks, supervised by the nurses. And my daughter was telling me that one of her friends, who was a medical student, said to her afterwards, you know, Ray, until I did this secondment, I thought nurses had no brains. Of course, she killed him at that moment. You know, isn't it interesting? We need to understand, not only know, but understand.
Thank you.
We all bail each other out, don't we? And that's through the knowledge, where it might be that little simple statement, would you like to try this medication instead of that medication? You might have some lignocaine there. You might want atropine.
Okay, Mark, next question.
Yeah, it's actually quite related. I'm going to skip one there, just talking about flat healthcare teams. And it was something that John, I think, had spoken about. And we have a question in relation to flat healthcare teams. And do we have any examples of ones that might be nurse-led in rural health settings, where maybe our medical colleagues don't lead them and take a back seat? So that's a provocative one there for John and for Bruce.
John's put his hand up. Volunteer.
Yeah, look, I think I've got, it's scanty. But actually, if you look at certain specialisms in nursing, you do get that. It happens in midwifery, and certainly in community midwifery, where the midwives actually run the show. It happens, certainly in my experience, with community psychiatric nursing. In fact, you know, as I said earlier on, there's no way I could have coped in practice with mental health issues without the community psychiatric nurses. So I would always refer to them and look up to them for advice. And it happens in palliative care as well. That's another nurse-led. Actually, doctors' input is often kind of, the nurses will suggest or will tell us what to do. So I haven't got a lot of experience of primary care teams, but when it comes to certain tasks in primary care teams, I think actually a lot of that is nurse-led.
Just in my experience, most of our rural hospitals have nurse managers, and they certainly run the show. And I think in most, we have a pretty respectful relationship between our various roles, and the nurses get on and do what the nurses do, and the doctors get on what the doctors do. And I think generally, it's not always the case, but generally I think there's pretty good respect on either side. On just a case-by-case basis, the nurses in our hospital love nothing more than to fully prepare a patient after hours and get them all sorted out, and then to get the medical input from me. So they love to lead that interaction and then get the medical input. I think there's still a need for each of us to have our own skill set and do the things that we do well, but I think we can all go, as I said, to the full of our scope in rural.
Thanks, Barbara.
I just want to give a shout out to a practice actually here in London. It's not a rural practice. It's called the Cuckoo Lane practice, and it's actually fully owned by nurse practitioners. And they employ a couple of doctors who work there, and it's actually won awards for being the best general practice in its area. So, you know, it is possible to turn these things around. I think, you know, my own sense is if you can develop a team where everybody's voice is heard, and it sounds like Bruce has a practice like that. And I worked once in a practice like that too, and it was absolutely the best time of my life, really. It was in Birmingham, Joyce, and it was just absolutely wonderful to have that colleagueship and collegiality in work.
Yeah, thank you. Shelley. Mute.
I just wanted to call back on Barbara's comment earlier. There's more than enough work for all of us. And I think it is really about assessing the local community and what workforce you do have available and, you know, divvy it up. We're there for each other. We're there for the community. And technology has been a significant support in Australia, particularly on our outer islands, our outer Pacific islands and those that border Papua New Guinea. Much of our COVID response has been through technology from the tippy top of Australia, reaching out to the many islands that we have around our top borders.
Thank you, Mark. I see the questions piling up.
Yeah, there's a question, just quite an interesting question, just in relation to engaging rural communities in designing services. And I know Bruce alluded to it earlier, but maybe if we could give a little bit more, if we had examples, it would be great for some of the listeners and tuning in today, just how you motivate and engage communities to get behind this, you know, a campaign for rural health. And I think that's the essence of the question there.
John wants to respond to that first of all.
Yeah, I mean, Joyce, I'm sure you're delighted that I'm going to use the word social prescribing here. That actually, you know, there's never going to be enough resources wherever you are, if you're a rich country, a poor country. But in fact, what you can do is use the resources that you've got in your community. And certainly something that I think probably started in the UK, it's now taking interest in other parts of the world. It's about social prescribing. It's using the resources, it's finding out what's available in your community and actually using that to engage patients. Often things in rural are, you know, often the problems are often related to things like isolation, like to loneliness, to bereavement. So it's about trying to engage your population, you know, people who are isolated in providing that kind of companionship, that company. It's using sometimes the faith-based services that are there, you know, for the mosque or for the church or whatever. It's being immersed in that community and realizing what you can use to improve the quality of that community. And as you know, Joyce and Barbara, in the UK, practices actually have individuals now that are identified in the practice that doctors and nurses can refer patients to, that actually will put them in touch with some of those services, some of those activities that are happening. So I think social prescribing is a way of understanding our communities and understanding how they work.
Do you want to go on to the next? Bruce would like to.
I just want to make a comment. I think rural communities have kind of got to the point of like a lot of communities, particularly those that are disadvantaged, they get to a point of despair where they just think they can't influence things anymore. They can't get what they need. Often they're spoken down to by some city-based administration saying, we'd love to give you a doctor, we'd love to give you a nurse, we'd love to give you other things, but yeah, we just don't have them, can't get them. And I think what certainly in the doctor area in Queensland, we turned that around by starting a rural generalist training program that actually produced doctors for rural areas, specifically with the right skills and the right competencies for rural areas. And all of a sudden, rural communities were saying, I think I'll have one of those, thank you. I think I'll have one of those, thank you. They could actually have a line of sight to their solution. Too often they, and I think it's the same with remote nurses, it's the same with rural nurses. We need to show them the product. It's up to us who influence policymakers to say, this is the product that rural communities deserve and can have, and then the communities will ask for it. But if they can't see it, they can't ask for it. They don't know what they're missing out on, really.
Okay, might be our last question, Mark.
Yeah, sure. I wonder if we would have a minute before we get to the last question. Just some colleagues from Cameroon on the very same or similar vein are asking about that political influence, Bruce, because they started the Nursing Now campaign and the Nightingale Challenge, and they just didn't seem to be empowered and couldn't find the empowerment channels that you were talking about, the political channels. So I'm just wondering if there's any advice maybe from yourself or Barbara for our colleagues in Cameroon before we go to the last question.
I'll just make two comments, I think. One is, or three comments. One is to harness the communities, so get the communities on side. The second is develop a product. So you've got to develop something you're going to sell. And one of my favourite phrases that I've used over many years is you give the politician the problem and the bureaucrat the solution. So you have a talk to the bureaucrat behind the scenes and they say, we'd like to we'd like to do this program, and the bureaucrat might necessarily be empathetic. They might say, oh, no, I don't think we'll be able to do that. Then you go and see the politician and say, we need this. The politician turns across to the bureaucrat and says, what do we do? And all they can think of then is to pull out of the back pocket what they've just been talking to you about, and that's their solution. And they go, oh yeah, I just happened to heard something about that. So I think giving them some solutions, even though they might not take them, and then build up the political heat on that so that they've got enough, and it makes everyone feel good. The bureaucrat all of a sudden has a solution that they can give to the politicians. So that's just a bit of advice from 40 years playing in this game.
Barbara?
Yes, thanks. And to our colleagues in Cameroon, so sorry it hasn't been possible to get more traction with the Nursing Now group, but don't give up. Please don't give up. There's a couple of really good opportunities, and I endorse absolutely what Bruce has said. And these opportunities will play into that, I think. The first is the strategic directions on nursing and midwifery that came up at the World Health Assembly in this May. Find out if Cameroon was there and signed on and endorsed these strategic directions, because if they did, if your minister did, they're accountable for implementing it. So there you are immediately. Now you have these policy options that you can look at and see how far away you are from having them implemented, and you can hold your Ministry of Health accountable for that. And please do, and maybe you yourself as an individual can't, but have you got a professional association who can? And you know, working with your allies is really important. I'm not so familiar nowadays with the situation in Cameroon. I used to know it quite well, but it's been a while. But you know, who are the powerful professional associations in Cameroon? Can you go and talk to them? Can you go and give them your point of view, show them the data, show them the strategic directions? Do you have a chief nurse in Cameroon or a senior nurse in the ministry? Go and see the senior nurse. How can you support that nurse to bring about the changes that you would like to see in Cameroon? So this is another team game. You know, we have to support each other in making the case and in looking for results. And that brings me to the second thing that I think we all as nurses need to know, and that's the significance of the data that we do or don't have in our country. I'm sure Joyce will endorse this with me. We need to know, we should have at our fingertips, how many nurses are there? What's the epidemiology in Cameroon? What are the demographics? What are we going to need in 10 years' time? How many nurses will retire in the next 5 years? How many nurses are coming into the workforce? We should all be able to talk about these data. And then what's, you know, the epidemiology, what are the significant illnesses? What's coming down the pike? How did you deal with COVID? What was the supplies interrupted? You know, all of that has to be at our fingertips, because that's the armor we have. That's the weapon we can use to go and make a case for what we need.
Okay, thanks very much.
Yeah, final question over to you, Joyce. I think it's time for you to maybe take on the final question.
Okay, so this is where do we go from here? So really what I would like is quick fire responses from each of the panelists, and please participants in the on the webinar, if you'd like to put some in what you need or what we need to go forward in the chat facility. So starting with Barbara, is that all right for you?
Sure. What do we need going forward? Well, in some ways, that's a sort of 4-hour answer, really, because I think we need a lot of fairly fundamental changes. But one of the sort of adages we had in the Nursing Now campaign is something I think we all need to sort of think about every day, and it's this: everybody has something to teach, and everybody has something to learn. And I think if we remember that every day, it's everybody, no exception, you know, the patients we meet, the colleagues we meet, everybody has something to teach us, and we have something to learn from everybody.
Thank you, Barbara. Bruce?
Yeah, I think the message, I think, from me in rural is get your voice heard by getting organised, get organised with your doctors, try and get that partnership with your communities, develop the skills that you need and show off those skills that you can do them in rural areas. And as I said, try and give the bureaucrats the solutions to the problems you're putting to your politicians.
Thank you, Bruce. John?
Thank you, Joyce. Just really 5 comments that I think are really important. It's about status and recognition. It's about developing leadership. It's about education and training. It's about academic development, and about generalism and promoting generalism. How we do that, that's really the difficult question. It is about looking at events and looking at events that are either co-badged or are specifically towards nurses. It's about a media campaign, and I don't know how we can get around this. Perhaps we need to go to Gates or whatever, but perhaps something quite simple that we could do is continue to run some more webinars, and also perhaps we need another edition, if the journal will allow us to do another journal, so it gets into the habit of people beginning and encouraged to start writing. You know, it's not going to happen overnight, but it's small steps rather than big leaps.
Yeah, I know some of the authors have joined us today from and they are actually driving forward the work that they've started on research and taking it forward. Shelley?
Yes, so professional generosity and collegiality. We have enough work to share between all of us. Pick up that Albuquerque statement and put nurses' voices around the tables where decisions are being made. They'll lead you and support you in good stead. And let's just accelerate our capacities. We talk, but, you know, go to the consumers, go to the communities. What do they want? And, you know, enforce that through policy advancement, regulation, modernise our licensing into competencies in the sense that it is sensitive to the needs of those communities so that we can expand scope and get care at the earliest point of time, have treatment to those communities and lift the health and wellbeing, and therefore supporting the World Bank statements of economic viability around sustainable development goals and universal health coverage.
Thank you. Now I'd like to invite Andre Lemay and Anne McMahon for their closing remarks to this webinar and our conversation. Thank you.
Thank you all. My name's Andre. I haven't met you yet, but I've been listening to your conversation and I've really enjoyed being here. I'd like to thank you for such a stimulating conversation this morning, this evening, this afternoon, wherever you are in the world. But I'd like to particularly thank Joyce, Shelley, Barbara, John and Bruce. You really are truly inspirational. And also our audience and our partners in this conversation. Your role's absolutely vital in keeping this momentum going that we've started this morning. Your questions are absolutely spot on, and you really made our panelists think, which is exactly what we wanted them to do. So thank you very much. And Lou and Mark from JRN behind the scenes, your technological and organisational magic has been absolutely critical to success today. I always breathe a great sigh of relief at this moment in time, knowing that the technology has worked. So thank you so much for enabling that. I'm allowed to have some closing remarks, which is always wonderful. But what struck me really listening to the conversation we've just had is a consistent message that people living in remote and rural areas deserve the best care possible from a confident, competent, visible, heard, enabled and contented nursing and midwifery workforce, which is well led, well resourced, well educated and supported, valued, not exploited, and is safe in the broadest possible way we could describe. Now, I've got a couple of housekeeping jobs to do. I need to remind you at the end, before I hand over to Anne, that we will be sending you an evaluation form. Please fill it out. It's ever so helpful for the journal because we'd like to carry on these sorts of events. And we need your feedback on how successful or not they are. And also, please keep this conversation going. Keep up that momentum that you've all generated this morning. It's fantastic. So you can email our panelists, you can contact them on Twitter, you can email JRN and we'll carry on sending messages out to people via Twitter or Facebook. And also in the evaluation forms, if you just think you want to jot something down, tell us, we'll remember it, we'll try and pass it on. Thank you. That's my last word. And now pass over to Anne.
Thank you very much, Andre, and thank you to everybody. My last words are just around JRN. This is the Rural Health Edition that we referred to. You know, our mission and our purpose is about helping to make the connections between policy, practice and research explicit. And I really think the conversation today has demonstrated that in a very powerful way. So just to echo Andre and to thank everybody for their fantastic contributions. Now, to do this, to make these connections explicit, every paper we publish has a commentary alongside it, and that's often written by a practitioner, a policymaker, a member of the public, or indeed an academic. So we try and bring different voices into our conversations. And the other thing we do with every paper we publish is we ask every author to draw out those key points for policy, practice and research from the work that they've undertaken. Now this edition, this Rural Health Edition, is no exception to that. So we thought it might be quite interesting to have a look at those key points for policy, practice and research and look to see if we could theme them. And we've done that Now, I don't know if, oh, here we go. Just like magic. Thank you, Lou. Fantastic. So these are incredibly high-level themes of those key points for policy and practice and research that were brought out from reviewing this one edition on rural health. And the overarching theme, which has come through the conversation today without any measure of doubt, is about understanding context and engaging in that context and the people within it to understand it. And I was really taken by Barbara's comments around gender and culture, interdisciplinary culture and so on. All of these things are about the context in which we work and understanding that rural health context. And oh, I love that geographic narcissism. I had to write that one down from Bruce. I've not heard that one before, but I have come across that really central thinking around urban communities and how that can skew policy. So understanding that context and knowing how to engage with it is really key. And the other themes that came that kind of underpinned all of that, which we've touched on today, are education policy and the practice of education, research policy and methodologies that are relevant to the communities that you're engaging with, service delivery and organisation, interprofessional collaboration that came up time and time again, and clinical practice and improvement. Now, this is just, as I say, one edition of this journal and some of the kind of headlines of the themes that emerged from reviewing what we published. And we just thought we might like to leave these with you as part of our parting comments for some more food for thought to perhaps inform that ongoing conversation that is so important to keep the momentum going and to enable collectively health and social care professionals, and of course our interest in particular in the nursing contribution to that, to have the maximum impact for the better of everybody, particularly those in rural communities. So I'm just going to ask all the panelists now to come back on screen and to wave their goodbyes to you. Thank you to everybody. Are you coming, Joyce? We lost Joyce. Thank you. Goodbye.
So thank you, everybody, and everybody that's joined in the conversation. And we will be in contact.
Go well, everyone. Go safe.
Been a pleasure.